Welcome to the Dose of Optimism, where I talk to the optimists in healthcare. My name is Omkar Kulkarni, and I work at one of the world's best children's hospitals, where I lead innovation. I started KidsX, which is a premier international startup accelerator for pediatric innovation. And over the years, I've met thousands of startups, investors, and innovators. Every one of them has a story, and every one of them is optimistic about the problems they're solving. On this podcast, you'll meet amazing people who will share their stories and what makes them optimistic about the future of healthcare. A little note before you get into this episode. This podcast is for informational purposes only. We are not offering medical advice, and we're not endorsing any products. Please talk to your own physician about your health or the health of your children. All right, let's get started. Health policy, specifically public health policy, is so important to making sure that everybody in this country has access to high-quality, affordable health care. Tom Priselac has spent the past many decades on the front lines of healthcare delivery and health policy. As president and CEO of Cedars-Sinai for 30 years, as chair of the American Hospital Association's board, while the Affordable Care Act, aka Obamacare, was being drafted and passed. I spoke with Tom about important health policy decisions that have shaped our healthcare landscape today and what we need to do to improve our health systems for the decades to come.
Happy to be with you today. Thanks.
So I wanted to start with 2009. You were the chair of the American Hospital Association at the time, just as the Affordable Care Act was getting written and approved. Do you remember what the original version or versions of the policy sounded like to you and how then it evolved over the negotiation and passage of the ultimate ACA?
I think there are certain principles that the administration had that they were looking to achieve, principally two things. One was expanding coverage, insurance coverage. At the time, there were some 44 million people across the country, over 4 million here in California who didn't have health insurance. That was really the number one goal. But at the same time, there definitely was a goal to try to address the proverbial issue of the cost of healthcare as best as possible. Those core principles were there from the beginning. And the way the process played out is similar to the way health policy plays out in general, frankly. The truth is, there are a number of different ways that work from an economic standpoint to achieve those two goals. But ultimately, what comes through in policy, and this is something people just underappreciate, ultimately what does come through the legislative process are things that are socially acceptable enough in order to be politically viable. And so I know there's a lot of debate about the ACA and was it good enough and was it good or bad? But at the end of the day, it was what was possible from a political standpoint to try to reach those goals.
We tried for decades with various administrations of both parties to pass some sort of meaningful healthcare reform. And there were different things that were done along the way. There's CHIP and there's the prescription medication coverage that was enhanced for Medicare and different policy things that incrementally made changes. But this was, I think, the first big swing at closing the gap on the uninsured.
For sure, it was the biggest swing. And essentially, the focus of the policy in the end had to do with some of the issues that are part of the cultural wars in the country. For example, was abortion going to be covered or not, as an example? And then, of course, the other major question was how was it going to be paid for? That took place in the last year or so was efforts by the Obama administration to work with the Hospital Association, Medical Association, the device manufacturers, pharmacy, all of the individuals involved in healthcare delivery, and working with them to identify how the funding for an effort like this could be put together. The question of expanding Medicaid coverage, I'm certain, was part of the idea and part of the concept from the beginning. There were other ideas. For example, the idea of allowing people with certain income levels to buy into Medicare. There are a whole variety of different ideas that were discussed and tossed around. But in the end, as a pragmatic matter, building on what existed and then creating something new ended up being the most practical way to achieve what they were trying to get done, which was to expand Medicaid, number one, but then also the creation of both a federal exchange and a state exchange. And as has been true about the American healthcare system going back to when Medicare and Medicaid was created, The political realities are anything in the country related to healthcare ultimately ends up with a federal component and a state component to balance the political issues of giving states flexibility that I think necessary, but without providing some flexibility at the state level, nothing would have been impossible politically.
So if we look at the value that it's brought us or the impact it's had, obviously there's more people that are insured or have been insured over the course of the last 15 years. What else have we gained as a healthcare system nationally as a result of the ACA?
There are several things, some of which are really unrecognized. But first, let's not go by the question of the number of people who benefited from expanded coverage. I believe the number is now down somewhere around 20 or 25 million people. That varies from time to time, I think, based on what's happening, among other things, in Medicaid coverage. And to the extent it hasn't covered more people, that had to do with the states that were not willing to expand Medicaid coverage. And so the potential has never really been realized, not as a matter of the ACA, but as a result of state level decisions about expanding coverage. In the decade following the passage of the Affordable Care Act, the rate of increase in healthcare spending did drop in a meaningful way. And there were several years in a row in which the growth in healthcare spending matched the growth in GDP. But those are things that oftentimes don't seem to make it into the larger coverage.
Because if you look at any public health textbook in the decades prior to 2009, a rate of increase of healthcare expenditures significantly outpaced GDP growth. And so that was a problem. It was unsustainable. And I think this at least bent the curve down a bit. I think it may have picked back up recently after the
Right.
pandemic, but it did create some tools, value-based
Right.
care and other tools to help us think about how we can reduce costs where possible.
It did do that, and as you mentioned, with the creation of the Center for Medicaid and Medicare Innovation and other provisions in the act, it did prompt a lot of new payment model experimentation that's taken place and has been picked up in the commercial insurance market as well. The challenge is the Affordable Care Act was never designed, and unfortunately, we struggled as a country to figure out how to address the real core issue related to healthcare costs, and that is what the cost is to provide the care. Healthcare is a labor intensive service, and the input costs, whether it's physicians or nurses or pharmacists, there are severe and have been for decades, frankly, throughout my career, severe shortages in those areas, with the predictable result of wages in those areas rising faster than general inflation. But those are issues that are beyond the Affordable Care Act. Those are the issues between the drivers for internal cost increase to deliver the care, issues related to appropriate and effective utilization of medical care and the overutilization that still exists and opportunities to improve there. And then the advances in medical and scientific technology itself and the additional cost associated with the kind of things that we're able to do now that are saving people's lives and improving the quality of people's lives. Those are the things that have the biggest impact on the increased cost in healthcare.
Discovery and research often has a very high amount of resources required in the earlier phases that then diffuse over time.
Sure.
And we've been blessed to have, over the last 50 to 100 years, a leadership role as a nation in terms of providing the resources and the infrastructure to support research and breakthrough treatments and diagnostics and devices and other things that people perhaps take for granted as they think about the graphs they see around cost of healthcare. Baked into those graphs and that data is the upfront investment in drug discovery and treatment discovery and things like that.
And the way healthcare is financed in America has allowed those things to happen, which, depending on where you sit, people may have different opinions about it. But there's no question that the American healthcare system has fueled the development of scientific and medical technology around the world and has raised the level of expertise and capability in terms of providing care.
You've been a big champion for public health. So, beyond health policy, public health in general, as we look over the next many years, what policy levers are available as we think about strengthening our public health infrastructure in this country?
It's among the things that I am most concerned about right now, based on certain policy decisions that are being made in Washington. Because at the end of the day, the kind of things of a public health nature that are the greatest challenges can only be effectively addressed with appropriate federal investment, whether that's investment in the CDC and the country's ability to monitor. What I'm speaking to in particular is the issue of infectious diseases, which in an increasingly globalized world will only increase. So the infrastructure to number one, monitor what's happening and knowing what's happening around the world and in the United States is key. And then second is the capability of the response system, which is a very patchwork quilt around the country, largely based on the relative economics of different states. In the wealthier states, there is at least the basis of a public health infrastructure to be able to support the interventions when necessary. But there are many states around the country where that does not exist. And therein lies one of the greatest challenges. What's not appreciated and understood to a great degree is the role of America's hospitals as part of the public health infrastructure. That's certainly true as it relates, especially in the case of children and pediatric care, but it's also very much a function of what options are available across the country. And we need only look at the response to the COVID pandemic as an example of that. The ability of the American hospital system to be able to adapt to that particular challenge was one of the great moments for the American healthcare system in terms of being able to respond. Since then, the hospital delivery system in the country has been significantly financially weakened and reduced. And payment policies going forward are going to put us on a path for further reduction. So that's my concern.
Let's talk about COVID and the pandemic for a second, especially the role that hospitals played in the early response in both detection, epidemiologic spread and surveillance, and then also treatment responses. You were the CEO of a very big academic medical center at the time the pandemic hit. What are some examples of perhaps underappreciated things that hospitals did, whether it was the hospital you were leading or other hospitals, that perhaps people don't realize that were important to those early days of the pandemic?
Well, an important one I would mention is the public private cooperation that actually got stood up in a very short period of time in terms of the collaboration here in California. Now, my comment speaking to California specifically, the kind of collaboration that took place to put together the data and the reporting systems so that the volume of cases and other relevant information for public health planning purposes was made available. And then the policies that institutions put in place, especially in the early days. We all, as a country, we seem to have short memories. And a lot of the criticism of what occurred at the time fails to remember that for the first 90 days or so, there wasn't a lot that was known. And as a result of that, policies had to be put in place appropriately, I believe, to protect the public interest. The institutions around the country bringing to bear the resources they had available to manage both the treatment side of things, but also the role that hospitals played in advancing the vaccine programs in the early days, I think was particularly important.
So we've talked about federal investment and the perhaps an erosion of trust that people may have as it relates to the science that comes out of public health institutions and public health leaders.
There are multiple root causes, but there's no question, and this predates COVID. It's been building over a period of time in which the public trust in large organizations, whether it's government or private organizations, has only been declining over that time. And it's combined and enabled by the phenomena of truth decay. And some very organized campaigns have been effective. Frankly, otherwise, I don't know that we would be in the kind of polarized environment we are. Some very effective campaigns to try to undercut the validity of scientific work that's been done over the last several decades. And I am hopeful that we'll be able to return to a fact based approach and a recognition of the limitations of science. It's not a question of 100% accuracy. That's not how science works. Getting a greater public understanding of the basis of scientific inquiry and the meaning of scientific results, I think, is going to be an important issue to address going forward.
Let's talk a little bit about pediatric health and children's health. It often gets overshadowed as we think about policy creation or policy debates that we have. At the national level, what's needed to improve pediatric care access and outcomes, specifically for the vulnerable populations? I think people forget, for example, that 40% of all Medicaid recipients or Medicaid participants are children. Half of kids that come to children's hospitals are on Medicaid. So it's a population that I think we sometimes forget to think about when you think about health policy. What do you think the opportunities are there?
I think the opportunities remain enormous on multiple levels. One is the access question, which in part is a function of the adequacy of payment and the challenges that exist for families who are seeking care for their children and the challenges that patients covered by Medicaid in general face speaks volumes about the challenges that are facing pediatric care across the country. In those states in which Medicaid expansion doesn't occur, by definition, the access problem is only extended. My own personal feeling is that this goes against what's likely going to be politically viable. But until and unless a certain federal floor is established for Medicaid coverage for children in particular, that is a key necessary change in order to enhance what's available for children around the country.
I've heard various people speak about Medicare for children instead of a state by state program, similar to how we have federal health insurance available to people over the age of 65, a federal health insurance program available to children. Do you think that's feasible or is that possible?
That's a very succinct way of describing what I was trying to say a moment ago. Unfortunately, I have to couple that with I think that it's an enormous political mountain to climb because I think, frankly, if we could be there, we would have been there by now. The philosophical differences that seem to occur around the country with regard to Medicaid coverage have prevented that from happening until now. I don't know that there has been what I would call a truly well organized process to focus this discussion on children, because I do think that if there is potential for a breakthrough, having such a discussion around children might be the vehicle for that to occur and cross over in some of the states that have historically resisted expanded Medicaid coverage.
I've always thought it was going to be a senator or senators who have had personal experience with their own children navigating pediatric healthcare to require that type of push because I think that personal experience that parents have opens their eyes to the broken system or the system that needs to be optimized. If there were to be somebody to have the resilience to push through the challenging way of doing it, I think it'd be a parent who has the authority and the ability to be on the floor of the Senate or the House.
But beyond coverage, the coverage itself doesn't guarantee access. And part of the challenge is the thought that there would be additional new money coming into the system is problematic. The challenge today is that accessing the system because of adequacy of resources, whether it's physician services or with the demise of many rural hospitals and the failure that's happening in urban hospitals that serve vulnerable populations in particular, those are creating very real access challenges. I don't see a good solution for that in the short run, other than the innovation that will, I think, continue to come out of the delivery system and the people who are doing their best to try to optimize the access opportunities.
Let's talk about that. So let's say 10 years from now, how will healthcare delivery look different? What do you think the innovations are at a high level that you think are promising as we think about delivery?
Number one would be the potential for telehealth and telemedicine to play in addressing the access issues. We learned the potential for that in the pandemic. Things have dropped off since the pandemic, and now they're back on the rise again. And I think we'll see more of that. I think the ability to do that actually will be enabled by artificial intelligence, both as it relates to streamlining what I'll call the intake process. That's part of the American healthcare system. But also, I think the enhanced productivity of both physicians as well as nurse practitioners and physicians' assistants that will come as a result of further development of artificial intelligence in support of, not as replacements for them, but in support of them, I think will play a key role. And then lastly, healthcare delivery will increasingly become organized into organized delivery systems going forward. Whether people want to refer to that as consolidation or not, the resources that are going to be required will ultimately drive further systemization of the American healthcare system, which is a necessary and a good thing. Obviously, appropriate safeguards have to be put in place as a result of that. But at the end of the day, in order to achieve what's required, bringing the benefit of economies of scale, and in the area we're talking about here, economies of capability, clinical capability and management capability to put together the systems to achieve what it is we're discussing, I think will be an important requirement in the future that can only be met by a more organized delivery system.
I've heard you talk about your grandkids quite a bit. I imagine these days you get time to spend with them. What's your favorite piece of advice that you have for your grandkids?
One of the benefits of being in the semi-retired state has been the opportunity to spend more time with them and be a part of their life. If there's anything I've tried to share with them, it's just the importance of treating everyone you come across in this life with respect and compassion and carrying the underlying values that go along with that into every aspect of their lives. I hope that's a message that they've heard from me, and I hope it's one that resonates with them for a long time.
When I worked with you, one of the things that I remember you regularly saying was to always do the right thing from a leadership standpoint. And I think that aligns with the advice you give your grandkids. And I think it also aligns with everything you've been talking about as we think about how we need to improve healthcare policy, how we need to think about the future of healthcare. I think if that's our North Star, always doing the right thing, I think we'll be in good shape.
Yeah, there's no question. The world can never have too much empathy.
Tom, thank you for joining us on the show, and I really appreciate your time.
My pleasure. Thanks, Hamkar.
And now, Patient Stories, brought to you by ICANN.
For this segment, I partnered with ICANN, the International Children's Advisory Network, to share the stories of pediatric patients from all over the world.
I was diagnosed with small bowel Crohn's disease when I was about 13 or 14 years old, and I had a pretty long journey to getting diagnosed. There's a lot of different tests and trial and error, and navigating that, I wanted to be more involved in my own care and have more of a voice and more of an impact on the decisions that were being made about me. It's been so amazing to be a part of having a voice in pediatric healthcare and making sure that kids are heard and their opinions are valued in the industry.
So, if you were talking to leaders at a hospital, what advice do you have for them? How can they make healthcare better for kids?
I think the main thing I would say is just talking to them. I feel like sometimes clinicians or healthcare professionals, even just subconsciously, end up talking more to parents or their caregivers because it's obviously they are so minors and may not understand as much, but kids also want to know what's going on and just to keep it real with what is going on with their health and the steps that are being taken or going to be taken. And so I feel like just addressing kids and knowing what they're feeling and what they want is so valuable from anything as small as what the process is like when they walk into the hospital or the provider's office, even if they're administering their own treatment or something like that is so valuable. I feel like just knowing, connecting more on a personal level with kids, like, I know clinicians are busy and they have so many patients to get to, but I feel like it's really nice when you get to know your provider outside of just a medical setting. If they're talking about school or maybe what activities you do and just getting to know you on a little bit more of a personal level, I think that really adds to the experience and makes it feel like a more safe place to bring any concerns and open up the conversation more to talk about health.
My next guest is a Harvard professor. He's the man behind vaccines.gov and Health Map. He's been recognized by the National Library of Congress and the Smithsonian. His research was critical in the early detection, surveillance, and response of major outbreaks, including H1N1, cholera, Ebola, Zika, and COVID 19. He even won an Emmy Award for his medical reporting during the pandemic. And he is the Senior Vice President and Chief Innovation Officer at Boston Children's Hospital. I hope you'll enjoy my conversation with Dr. John Brownstein. So, I read about this OpenAI healthcare partnership. Very exciting, and congrats for being one of the early adopters.
We've actually had a long-standing partnership with OpenAI now for several years. One on the area of building our internal ChatGPT tool that we've rolled out and have had a lot of success. But that UI is an internal build that requires resourcing and maintenance. It has a lot of amazing customizations to our own environment, but people still love using the consumer tool and they're used to that. And so as we think about innovations that we want to bring into healthcare, my view has always been try to meet people where they are. They're using these tools in their day-to-day lives. They should be able to do the same. We did this many years ago with Uber, where we brought Uber into healthcare, as opposed to building your own logistics platform. And this is very similar to that. There's an opportunity to take the best of what OpenAI has, and now that they're moving to a HIPAA-compliant platform, test out and how that goes against something that's more homegrown. We're very excited, and I've actually started testing it out. I linked my health record data to ChatGPT. It was seamless, and you can just have a long chat about all your clinical history. I can imagine some people are already doing this, but they're copying and pasting lab results. This is giving a direct connection to your entire record. It was pretty unbelievable. It flagged some things I didn't really think about in my labs. It was very insightful. There's obviously risks over reliance on the kind of output, but these tools are getting better and our patients are already doing this. Our patient families are already doing this. We want to figure out how to optimize their patient journey. I think the use of AI is a big part of that. Very different than some of the other forays of tech companies into healthcare. There was efforts from Microsoft and Google and others in health records. This required a lot of porting over data, but the utility wasn't immediate. Here, like the utility is within seconds, you can ask questions about your health data and make potentially important intervention decisions.
Are there agentic capabilities part of this OpenAI healthcare
Yeah.
that are on the roadmap?
I think we have a very in-depth roadmap around agentic AI and a wide range of use cases, whether that's in rev cycle or supply chain work or anything, especially on the administrative side, there will be an agentic functionality. And that's one value add of the new OpenAI tools. Using our internal tool, we can't sometimes take advantage of some of these newer agentic functionalities, but with being sort of locking step with the consumer tool, we'll be able to be a little bit further ahead, because I think that's one complaint. People go to our internal tools, oh, it doesn't have this and this, what I'm used to. And so if the goal is to upskill our entire workforce, get people using this, figure out how to get people working at the top of their license, reduce sort of the repetitive manual tasks, reduce burnout burden, and streamline patient experience, the more adoption we get, the better.
You're an epidemiology, infection control expert. Whether it's this specific use case at Boston Children's or just globally, where do you think opportunities are as we think about disease identification, disease prevention, disease spread, that we could think about the use of these types of tools that are coming out from a generative AI standpoint?
We've been using AI for infectious disease surveillance and response for 2 decades, whether that's in data mining, data analysis, data summarization. And now with generative AI over the last several years, it's really upped the game in terms of our ability to do global disease monitoring. We run several programs in a world where public health is getting defunded, or underfunded, which I've experienced directly through my work. AI becomes this opportunity to tackle exciting things like finding the next emerging virus that like COVID, but it can also just create efficiencies in data analysis and reporting. Our local public health and national public health are completely underwater with resource constraints. So adding these sort of co-pilot tools in the mix are fundamental to being able to keep the lights on right now. We're also doing some really exciting things in diagnosis at the hospital with AI in the rare disease front. We were funded by OpenAI to look at the use of OpenAI's large language models to help reduce diagnostic odysseys. And what we're finding is that the combination of large language models plus deep phenotyping and genetic information, we have diagnosed many kids with rare conditions that were once undiagnosed because of the deep ability of research and reasoning that large language models have that far outpaces our ability, even of the world-class geneticists here at the hospital. So this amazing combination of expertise plus large language models is going just beyond pure efficiency gains, but it's really moving into discovery.
We've talked back office, we've talked clinical, we've talked research. What about academics? Boston Children's has a great teaching program. How are you thinking about using these tools with residents, with fellows,
Yeah.
with med students that are coming through?
Absolutely. And we launched a tool called MedTutor, which is a large language model tool to help residents and fellows do differential diagnosis. So basically, a query based format to go through a case and make a decision around that particular case. We set these use cases ahead, and the learner can go through that case and come up with a diagnosis through chat that's going to go through voice and video eventually. And so, from a training perspective, it's going to be completely different than it once was. On the research front, we're using AI to support identification of potential hypotheses, and working with Google, they have a new product called Co-Scientist that allows scientists to help query and then come up with a potential output of what, with a research question, a potential sort of hypothesis for what is behind that particular question. Early efforts are showing it to be incredibly valuable. Obviously, there's going to be AI on the data analysis, on data collection, on data visualization, and even, of course, on the writing and presentation. That becomes trickier with authorship and IP, so that's still a moving target. But it basically is changing every aspect of research.
Are there any misconceptions that you hear from your folks at Boston Children's or others about AI that you wish you could clear up?
There are misconceptions. One is the hallucination area, which I know very early on that was pervasive, coming up with references that didn't exist or connections in data. Those things have been largely fixed in large language models. The course can still happen, but I think that became a front and center topic, which is less relevant today. And of course, there are tools that can help constrain output of models. Many of our physicians use open evidence. Hallucinations aren't sort of part of that sort of AI tool. So I think that's a big one. And I think just generally speaking, there's a disconnect. People use these tools day to day, but still for whatever reason can't get to the mental leap of, oh, wait, this helps me in my day to day job. You just had a call today with someone who uses it, but hadn't yet figured out, oh, wait a second, I can do all these things pretty easily in my work setting. We're still at the starting point. In an academic medical center, there's been so much AI now, and at the hospital for well over a decade in many parts of the organizations. There's a wide range of expertise and level of proficiency. I'm learning so much from so many people in different parts of the institution, whether it's in the ICU, radiology, or pathology, that are more versed on the AI tools than I could ever be. So we're navigating, trying to let all boats rise, but there's high variability in proficiency right now.
Last question. What makes you optimistic about AI and where it can go? What's your biggest hope for how we can use it in pediatric care?
We've gone for some of the low-hanging fruit, operational efficiencies, documentation. We're moving into areas that are much more patient-facing. That's where I'm really excited about. There's a whole access component, an equity component that I'm absolutely excited about. We just rolled out language translation, so we can offer discharge notes in 120 languages and do so much more efficiently at a lower cost. That's just one example, but if you think about helping people prepare for their healthcare journeys and post journey, the AI tools are going to be incredibly valuable, and they will supercharge our ability to provide care and, of course, improve the experience that people have in interacting with our health system. We've been slower on the patient side around improving and streamlining the patient experience, but that to me is where we should be pushing. And that's what families are looking for. They're looking to take more control over their data and their lives. So I think that's a really nice conversion.
There's this quote about the future that sticks to me. I'm curious your thoughts on it. Let's say in 2030, AI will be so pervasive that folks will be asking hospitals that aren't using AI much, like, why aren't you using it for this? It'll be to a point where there's somewhat of an expectation that AI is used so that quality is excellent, it's efficient, it's patient-centric, et cetera.
How would you not want that? You can't expect your provider to have every aspect of knowledge of every recent publication or every publication that's happened in the last century. Like, I think that's an expectation that patients should have. I think that's especially true on primary care, where primary care physicians are spread so thin, have so limited amount of time to offer. And by the way, the adoption is showing that among our physicians that they recognize this too. So I think that it's a nice convergence. I think there's an expectation of patients, but I think physicians are seeing it across the board, seeing a life that they can't go back to.
You talk about your discharge translation tool, right? So I can imagine a future where if someone didn't offer that, where they spoke a different language and they were given materials that were not there, at some point in the future, someone's going to say, don't you have an AI that can do this? Maybe
Right.
not today. You're early and ahead in that space, but 5 years from now, I could see that being an expectation that consumers have, providers having the same expectation that they have some synthesis tool that can help them write notes and documentation and differential diagnosis. So for all the things that you're building now are, I think at some point in the future, going to become expected in healthcare.
Hopeful. The other option is the patients show up with their own tools,
Or that.
their own AirPods that do live translation. And there's going to be some of that too. A health system should be investing in these tools and not just letting consumers have to push it. So that's what
Well,
we're trying to do at Boston Children's.
you are leading the way, John, and I appreciate talking to you. It always makes me optimistic about where we're headed. Thank
Right
you.
back at you, Omkar. Thank you so much.
All right. Thank you for joining us for your dose of optimism. Make sure to check out our show notes to get more information about our guests and the work they're doing. Visit our podcast page on the KidsX website to join our podcast community and to learn more about pediatric innovation. Thank you to our sponsors and to our presenting partner, KidsX. Please subscribe wherever you get your podcasts, and remember, it takes a village to make sure our kids grow into healthy adults. So volunteer at your local library, help out at the community center, and if you're so inspired, donate to your local children's hospital. All right, see you next time. The content, views, opinions, and information presented on this podcast do not reflect the views of Children's Hospital Los Angeles or of the sponsors of the podcast.